Today, I'm going to speak about my topic is adjunct pain management medications. My objective today of the lecture was we will define the adjunct pain management and its role in enhancing primary pain treatments. Then we will explain the importance of incorporating adjunct medications into pain management protocols. And then we will explore different classes of adjunct pain medications such as antidepressants, anticonvulsants, muscle relaxants, and corticosteroids. Then finally, we will analyze some clinical studies and evidence supporting the efficacy of adjunct medications in pain management. First of all, what does it mean of adjuvant analgesic? The term of adjuvant analgesic or co-analgesics originally referred to the small number of drugs that were approved and marketed for indications other than pain, but were found to be potentially useful as an analgesic in patients receiving opioid therapy. To simplify it, adjuvant analgesics is a drug that has a clinical use other than pain, but is used as an analgesic in selected circumstances. There are some principles of using adjuvant analgesic. In the management of pain associated with serious illness, adjuvant analgesics are usually administered in conjugation with opioid therapy in an effort to improve outcome when an opioid does not provide satisfactory relief with tolerable side effects. And the fundamental concept of the analgesic ladder is that it's essential to have adequate knowledge about pain to assess its degree in patients through proper evaluation and to prescribe appropriate medications. As Dr. Ghattas before mentioned about the analgesic ladder, before it was 3 steps, but lastly updated in April to added 4 steps, which include the invasive and the minimally invasive treatment. So according to the pain intensity, we will start in the step 1, non-opioid plus or minus adjuvants. Then we will forward according to the pain, when it's more mild to moderate pain, we'll start to opioid plus non-opioid plus or minus adjuvant. Then we will forward to opioid from moderate to severe pain plus or minus non-opioid and adjuvants. And then lastly, if still persistent pain, already the patient having severe pain, we will forward to the invasive and minimally invasive treatment. We have different classes for adjunct medications. As we mentioned earlier, antidepressants, muscle relaxants, anticonvulsants, corticosteroid, bisphosphonate, local anesthetics. I will go through quickly for each class just to highlight what are the main important topics on this. First of all, antidepressants. Antidepressants, we have the main category, tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors, selective serotonin reuptake inhibitors, and atypical antidepressants. The main 2 groups in antidepressants that have an impact as adjuvant analgesic are tricyclic antidepressant and SNRI. Both tricyclic antidepressant and SNRI inhibits the reuptake of 2 important neurotransmitters, serotonin and norepinephrine. This inhibition increases the descending inhibitory pathway of the central nervous system related to the pain. So we will find these 2 classes are useful may provide pain relief in conditions such as neuropathy, arthritis, fibromyalgia, migraine, and chronic fatigue syndrome. The main medication from tricyclic antidepressant is amitriptyline, and from SNRI is duloxetine. There is a review showed in a research to show the efficacy and safety of duloxetine in chronic musculoskeletal pain. It is a systematic review and meta-analysis. The purpose of this article is to evaluate the efficacy and safety of duloxetine in treating chronic musculoskeletal pain. The database, it evaluates the efficacy and safety of duloxetine versus placebo in patients in the population more than 4,000 participants in 4 countries to result that meta-analysis that duloxetine is statistically significant compared with the placebo control. And the benefit on 24-hour average pain, living quality, physical function, and global impression. And generally, duloxetine can improve mood and pain level at the same time. Another review also for duloxetine for treating painful neuropathy in a chronic pain or fibromyalgia. This identified 18 trial that includes more than 6,000 participants to assess the benefits and harms of duloxetine for treating painful neuropathy and different types of chronic pain. Also, the main result of duloxetine that doses of 60 and 120 milligram daily are efficacious for treating pain and diabetic peripheral neuropathy, but lower daily doses are not. So if you are treat a peripheral neuropathy, it's recommended to start from 60 and 120 milligram from duloxetine. On the other side, the effect of low-dose amitriptyline on low back pain with neuropathic component. It was a post-hoc analysis also. As we know, low back pain is a major health problem. Low back pain is a complex, heterogeneous condition with a limited effective treatments. The clinical trial examined the efficacy of low-dose tricyclic antidepressants, amitriptyline, in those with chronic non-specific low back pain. Moreover, chronic low back pain with a neuropathic component represents up to 55% of individuals with low back pain and is associated with greater disabilities, socioeconomic costs, and narcotic use than non-neuropathic pain. From my own experience, I found that amitriptyline is considered like a magic drug, really, especially on this patient who's having multiple disc bulge or a neural stenosis. It has a dramatic impact on their lifestyle. So the result of this study, the low dose of amitriptyline had a greater reduction in pain and disability compared with the active comparator group at 6 months. The other group is anticonvulsants that can be used as an adjuvant analgesic. So anticonvulsants can also be used as adjuvant in pain management for certain conditions. But how it works? First of all, it has neuropathic pain relief. Anticonvulsants are effective in managing neuropathic pain, which originate from the nerve damage or dysfunction. They can help by stabilizing the overactive nerve cells and modulating pain signals in conditions such as diabetic neuropathy and trigeminal neuralgia. Second, for anticonvulsants has a pain signal modulation. Anticonvulsants can alter the transmission of pain signals within the nervous system. They do this by affecting the neurotransmitters and ion channels involved in the pain perception, helping to reduce the intensity and the frequency of pain signals. Third, central sensitization inhibition. In conditions where the nervous system becomes hypersensitive to pain, it was like central sensitization, anticonvulsants can help to dampen this heightened response, leading to improved pain management in conditions such as fibromyalgia. There was a trial showing the different gabapentin, pregabalin dosages for preoperative pain control in patients undergoing spine surgery. This systematic review, published in August 23, to evaluate the association of pain, opioid consumption, and adverse event with different dosages of pregabalin and gabapentin in patients undergoing spine surgery. This was a meta-analysis with more than 77 randomized clinical trial. To conclude, the gabapentin 900 milligram per day was associated with the lowest visual analog scale, VAS score, and was found to be the best in terms of reducing opioid consumption, followed by gabapentin 1200 and gabapentin 600, then 300, and the last pregabalin 300 milligram per day and 150. So the upper hand with the gabapentin 900 milligram. Increasing the dosages of gabapentin above 900 milligram was not found to be associated with further pain reduction. The other group can be used also in adjuvant as adjuvant analgesics, muscle relaxants. Muscle relaxants divided into main groups: smooth muscle relaxants and skeletal muscle relaxants. Smooth muscle relaxants, it's called antispasmodic, such as hyoscyamin, dicyclomine, that can be used in intestinal, gastric, and bladder spasticity, irritable bowel syndrome. And the other group is muscle relaxant, such as baclofen, tizanidine, cyclopenzaprine, that can be used also in stiffness, strains, and sprains. Muscle relaxants also There is a published review about oral muscle relaxants for treatment of chronic pain associated with cerebral palsy. Palsy means weakness, and cerebral means this weakness having to do with the brain. So this comprehensive literature review briefly described the background and etiology of pain in cerebral palsy and proceed to review the available evidence for treatment with the muscle relaxants. Cerebral palsy is caused by abnormal brain development or damage to the developing brain that affects person's ability to control his or her muscles, accompanied by the chronic recurrent muscular pain. Treatment of pain is crucial and focus mostly on the treatment of spasticity. The finding of this trial, the use of oral muscle relaxant has gained ground and more evidence. Baclofen is commonly prescribed for spasticity for cerebral palsy. And more recent options include cyclobenzaprine and tenisidine. Cyclobenzaprine carries more significant adverse events profile, including CNS sedation. That's why baclofen is more commonly used rather than the other CNS acting muscle relaxants. On the other side, there is a botulinum toxin. Botulinum toxin is a neurotoxic protein produced by Bacterium Clostridium botulinum and related species. There are 7 main types of botulinum toxin are named from A to G. It prevents the release of acetylcholine from the axon endings at the neuromuscular junction that causing muscle relaxation and reducing the transmission of pain signals. So we'll find different medical uses of botulinum toxin, such as in treatment of migraine headache, chronic neck pain, eye disorders such as exotropia, hypotropia, overactive bladder, muscle spasticity, and cerebral palsy. Another review for botulinum toxin A for treatment of migraine symptoms, it was a systematic review. This review 24 high-quality articles evaluating the effect of botulinum toxin A in the treatment of migraine from 2011 up to the end 2021 were included to result the decreased attack frequency of vestibular migraine patients and improvement in the migraine disability assessment score and more than 50% reduction in headache day frequency, severity, and duration. Decrease the consumption of any acute medication and emergency visits. Another group also can be used as adjuvant analgesic is corticosteroids. Of course, corticosteroids have anti-inflammatory and immunosuppressive properties. They are commonly used as adjuvants due to mainly their ability to modify the body's immune response and then reduce inflammation by inhibiting prostaglandin synthesis, reducing the vascular permeability that results in tissue damage, such as in tendinitis, osteoarthritis, rheumatoid arthritis, Crohn's disease, and systemic lupus erythematosus. We will find another review also that supports corticosteroids used as adjuvant analgesics. And PMG published a research to show the effect of dexamethasone as an analgesic adjuvant to multimodal pain treatment after total knee arthroplasty. This randomized clinical trial. The objective of this trial to investigate the effect of 1 and 2 doses of intravenous dexamethasone in patients after total knee arthroplasty. The main outcomes measure, first, the total intravenous morphine consumption 0 to 48 hours post-operatively. Second, the level of pain intensity measuring using a visual analog scale at 24 and 48 hours. The result of this review concludes 2 doses of dexamethasone as an adjuvant to multimodal pain treatment with paracetamol, ibuprofen, and local infiltration analgesia significantly reduce morphine consumption and pain after total knee arthroplasty. I want to finish my presentation about this review. It was this review published in UK evaluating the common prescription analgesics and adjuvant analgesic as a marker of suicide risk. It was a longitudinal population-based study in England. This study, it was a case control study, included patients in age more than 15 years old who died by suicide between 2001 and 2019. Number of the patients, more than 14,000 patients in UK. The finding that suicide risk were highest in those prescribed adjuvant analgesics, especially pregabalin, gabapentin, and carbamazepine, followed by those prescribed opioids and those prescribed non-opioid analgesic. The interpretation of this review that analgesic prescribing was associated with higher suicide risk. This is a particular issue with regard to adjuvant non-opiate analgesics. So it's okay to use adjuvant analgesic, but you should be aware for the dose, what kind of the patient, which pain that you are treating, and for how long you are using this adjuvant analgesics. This is my reference. Thank you so much.